Still waiting for people filing in, and then we'll get started. Welcome to Thursday morning Grand Rounds to the HIV Center. Okay, I see it's starting to slow down. More people will join, but I'm just going to welcome everyone and make announcements for upcoming rounds before turning it over to my colleague, Dr. Gina Wingood. So thanks for being here. Welcome to HIV Center Grand Rounds. In terms of upcoming rounds, on November 21st, so Thursday, November 21st, we have Dr. Stephen Burrell. Steph Burrell, many of us know him. His presentation is entitled Structural Determinants of HIV and Sexually Transmitted Infections Among Sexual and Gender Diverse Communities in the United States. And then in December, on Thursday, December 12th, we have Dr. Elvin Gang, who will be with us in person, and that'll be a special seminar in person. You'll hear more about that. So please mark your calendars for that for December 12th. And his presentations for the Grand Rounds will be entitled Understanding Implementation Strategies that Address HIV Generalizing and Context. So without further ado, I want to turn it over to Gina Wingood to introduce today's esteemed speaker. And thank you so much, Dr. Siegler, for being here. And over to you, Gina.
Thanks so much, Bob, and good morning, everybody. It's my pleasure today to really introduce Dr. Aaron Siegler. Dr. Siegler received his PhD from Emory University. I was actually fortunate enough to be a part of his doctoral dissertation committee. So it's great to see Aaron here today. And he's just amazing, like so many of our who present here. Dr. Siegler is currently the co-director of the Prevention and Implementation Science Center at the Emory Center for AIDS Research. He's an associate professor in both the Department of Epidemiology as well as the Department of Behavioral Social Sciences and Health Education Sciences at Emory University Rollins School of Public Health. Aaron is heavily funded. He's either the PI or the MPI on 5 R1s from NIH, predominantly from NIAID. He has funding also from CDC and other agencies as well. Dr. Siegler has over 110 peer-reviewed publications. His research is really having a public health impact via implementation science on PrEP scale-up to reduce disparities locally and globally. Aside from his awesome academic credentials, Dr. Siegler is just a fabulous individual. Great to meet you here. Great to have you. And looking forward to hearing your presentation today. Thanks so much.
Well, thank you for the warm and lovely introduction, Dr. Wingood. So lucky to have you involved in my career throughout the career and involved. Honored. Let me get my presentation going. Okay. Can everyone see?
Yes, we can.
Yep. Looks good.
Okay. Very good. Okay. Well, thank you, everyone, for your time today. So I'd like to talk about how we can bring HIV prevention to scale through innovation. And I work with PRISM Health and the Emory Center for AIDS Research. So a brief overview of some of the things I want to cover today. First, I want to briefly talk about some of the basic epidemiology of HIV in the United States. I won't spend too long on that. Then I want to talk about some attempts at paradigm change that I or others have had interactions throughout my career. One is user-based health tools, and that's through the PrEP locator. Another area of paradigm shift is public health regulation, and that's involving condoms. Then another area is mHealth, and there are various approaches that I'll be covering today, all of which have come to scale in reality. And then, how we think about policy and policy analyses, and I'll conclude with some lessons learned. So, new HIV diagnoses in the United States from 2008 to 2022, what we see is that there has been improvement over this 14-year time frame. However, the improvement is kind of halting and limited. It's not where we'd like it to be. you do see a dip in 2021 and 2020 that's likely related to COVID. We also see the very disproportionate burden of HIV borne by Black persons and Hispanic persons in the United States. So I want to talk, I know that Patrick Sullivan recently, his longtime close collaborator of mine, recently talked in this series about PrEP to need ratio, but just to reiterate, I want to talk about a tale of two metrics. The idea of PrEP use per population and PrEP to need ratios. So if you look on the left, you see PrEP use per population. This is just a rate per 100,000 persons. And what you see is the rates by race over time have not, their trajectories are similar, right? So the rates of PrEP use by race ethnicity is actually not that disparate in absolute terms. But obviously, as I showed you in the previous slide, the need is not particularly equivalent. And so on the right, we can see PrEP to need ratio. And PrEP to need ratios are the number of PrEP users divided by new HIV diagnoses. And so here, higher ratios mean there's more PrEP relative to need, which is a good thing. But you see stark disparities and increasing disparities over time between 2012 and 2021 in the use of PrEP. This is by race ethnicity. So we see PrEP is not in the United States scaling up equitably. And I'll just note that equitably also means efficiently. If you give folks who most need PrEP, who are at the highest risk, if you get that group PrEP, it's also the most efficient way to distribute resources in a society. So it's both efficient and equitable, which is a nice coincidence. And here we have disparities by age group. We see that younger persons have the lowest PrEP to need, and persons 35 to 44 have the highest PrEP to need, and also disparities by sex. So we see that these trends continue. Notably, if we look at the trends over time, in no cases are they improving or even lessening. So, we obviously need some paradigm shifts. And if we think about where the HIV epidemic has gone in the United States, we need to keep seeking paradigm shifts. I think marginal change is unlikely to address our really substantial health disparities, and also unlikely to shift the overall trajectory of the epidemic. Paradigm shifts can change these things like new policies, new medications, improved access to these medications through structural changes are really critical. Just to note that you can have a paradigm shift that doesn't have to be a silver bullet. I mean, maybe paradigm shifts could be best represented by little shotgun balls, silver shotgun balls. They're not bullets, but they're part of a shotgun approach that might eventually really impact the epidemic overall. So PrEP, even as of 2017, we were approaching awareness saturation among men who have sex with men in the United States with over 90% awareness, and that has only increased. Now, notably, this is not equally aware in other groups, particularly injection drug users and high-risk cisgender women. But in many groups, PrEP awareness has approached saturation, but use remains suboptimal, as you saw in previous slides. So it's not necessarily, or at least it wasn't necessarily when PrEP first came out, easy to find a doctor willing to prescribe PrEP. And so here we kind of use the diffusion of innovations model to develop a database of PrEP providers. The things that people previously used to find PrEP providers were like web searches in their areas. There were massive lists on state health departments, sometimes in PDF file format, just 15 pages of PDF alphabetically sorted by county. And then also sometimes the health department said to call them. These resources were often buried deep in the parts of internet, some local health department web pages that weren't easy to access. There's kind of limited these are limited channels and limited agency for advocacy groups to really have impact. And so, we see our complexity in terms of diffusion of innovations is pretty high, right? The ability to leverage networks of influence. There was PrepFacts, which is a Facebook group, but really not optimally able to use their resources because they're so hidden. And then there are many barriers for people seeking care. There's no or minimal vetting of providers on these lists. And so some of them may not prescribe PrEP, some of them may just be referrals, some of them may be out of date, the contact information may not work. It's a daunting text to these providers lists, and then providers couldn't add themselves. So a lot of challenges, and here we, are you really a doctor? Okay, so we developed this database, PrEP Locator. We start out with a list from local city and state governments. We contacted non-governmental organizations. We contacted professional medical organizations who had surveyed their members, and we did web searches. And then that ended up with 2,400 clinics. We then deduplicated clinics, and then we called each and every clinic on the list. We also assessed licensure to prescribe PrEP. That was actually pretty easily done through state databases. But what you can see is that a lot of clinics did not prescribe PrEP. They didn't have a practitioner. They just did referrals. They might do it in the future, but didn't do it then. Another common thing we found, not presented in these numbers, that a lot of clinics, the front desk didn't know that they prescribed PrEP. So if you called them and asked the front desk, do you prescribe PrEP? The front desk is like, no, we don't. So then we would contact those clinics and say, hey, a doctor or somebody at your location has tried to add you to this, local, this source of PrEP providers. But we are, your front desk said, no, let us know once you fix that problem. And then we'd add them into the database once we did another call and confirmed that they prescribed PrEP. So we created this kind of front-end website at preplocator.org. And we did this with diffusion of innovation principles in mind. And so you can see we sought to lower barriers. We have options for people to search by clinics that provide PrEP for people without insurance and clinics that provide PrEP navigation assistance. We sought to lower complexity by showing location, how close the clinics are to people's search address. And then we sought to increase trialability by allowing people to visit the website of the clinic, get directions, right on their phone. And last, we sought to leverage networks of influence. And the way we did this, that little pane, add the locator to your site, it's just like a line of HTML code that anyone can pop into their website. And with basically no programming skills, this can be done. And it basically pops in this pane that you see right here into whoever's website it is. So it allows people to keep users on their website. It allows people to make the database easily accessible to users of their website. So, the places a public health intervention will go. One of our launch partners, Greater Than AIDS, put the PrEP Locator on their website. A number, about 20 local organizations put it on their websites. This one was DC Takes on HIV. You can see they just kind of popped the PrEP Locator into their website. The manufacturer, Gilead, placed the PrEP Locator on their website, and that is a major source of our traffic, actually. Because I think a lot of people interested in PrEP end up at manufacturer websites. And it also, in a perfect fit of public health need and public health prevention, it ended up on Communion as a tool. So I'm going to disappear that before anyone takes a screenshot. But we can, what better place can a public health tool be than there? And last, here's a post from PrepFacts and said the handy tool has been shared many times, but it's too good not to share again. And we also got some good scholarship out of this work. Here's a publication from AJPH looking at geographic access to PrEP clinics among MSM. And we're able to use census data and published estimates of the number of MSM per jurisdiction, and then we assessed using NHANES and other data, the assessment of how many MSM are eligible in each jurisdiction. And so we're able to estimate how many people are living long drives away from PrEP care. And a critical kind of assessment for travel time is 30 minutes. There's a bit of research that shows that folks are unlikely to travel more than 30 minutes one-way trip to prevention care or primary care. And so you can see that there's over 100,000 persons in that category. So 8 years post-launch, that was 1,200 clinics when we launched. Now there are over 3,000 vetted clinics. The CDC has taken over the program. So our long-term vision for this was to develop a resource and pass it to the CDC National Prevention Information Network, or NPIN. NPIN is a database of HIV and prevention services. And so we were actually really thrilled to be able to add that to their database and make the database even more publicly accessible to in more places. There have been over 2 million page views of preplocator.org and over 1.4 million unique users. So really substantial use of the website. And what's really nice is when I go to a PrEP clinic and I'll ask, what do you guys do when people change their location? They move. Invariably, they say, we go to PrEP Locator and we refer people over. So it's kind of amazing how it's used by navigators and the community it's such a simple tool, right? And we've just been sustaining it as a kind of accessible resource in collaboration with CDC. So just to note that when you make a great public health tool, sometimes it can also lead to really good scholarship. So we published a locator protocol just so that for other disease conditions, other medication modalities, that folks could really follow an exact protocol about how we developed our geolocated directory. We also published an assessment of the users of the PrEP locator in JADES. And then we published other geospatial analyses like correlates at the county level of having a PrEP clinic in the county. So lots of good scholarship can be had in addition to public health impact. So next step, we're working to try to get injectable PrEP providers added to the locator. So that's a thing that a lot of users are interested in. I think it's really critical. We want to update the user interface. It's been 8 years since we launched, and so it's an ancient website, archaic but functional. But we might like to improve the user experience, and then that we want to answer some research questions about injectable PrEP provider locations and how that influences injectable PrEP use. Okay, so on to the next thing. Why aren't people using condoms? This is my favorite article title I've ever seen. 50 Ways to Leave Your Rubber, How Men Rationalize Unsafe Sex. My much less interesting elements of condom use decision-making is sadly following that one. But basically, pleasure in almost every study where people are qualitatively describing why they're not using condoms, pleasure is a critical component. And here, even Sigmund Freud describe the challenges of condoms. So condoms are tough for people to use. It's not an easy thing. And in public health, it's important for us to optimize use of prevention products, right? And to minimize barriers to accessing them. It's not that condoms are the only answer or perhaps the only answer, but we want to make this as good as possible for folks who might want to use it. So does condom use matter? So here is an old modeling study, but I think really useful, and the model remains relevant. If you get 40% coverage of oral PrEP, this one's in Kenya, but you can see they're not that dissimilar across different epidemic settings, even despite very different epidemics, is a similar intervention to getting early treatment going. And is a similar intervention to 20% increase in condom use. So if you can increase condom use, it is a real challenge. if you can, there's a real, population level impact to be had. So, so I was approached nearly a decade ago about working with a condom company. And this is actually the next variant of the condom company. I'm kind of starting at the end because this is the end product that resulted from our research. But the idea of this research was really about fitted condoms. So if we gave people different sizes of condom options, would that, would that be a useful intervention? So is a condom just a condom? We went to the manufacturer. We had a nice little trip. You can see these really lovely displays. And I wanted to show you guys just a little bit of what a condom manufacturing plant looks like. So here you see the glass formers are being dipped into latex. The latex, this is in Malaysia, and the latex is taken from rubber trees in Malaysia. So the glass formers get dipped in, they come out. After a bit of time, they're spinning as they come out. I find this incredibly peaceful. It's exactly what our prevention world should be. And so the condoms get a second dip, and then they get tested in numerous ways. I have like a whole 20-minute presentation on the manufacturing of condoms that I'm not gonna pass you guys through right now, but everything from laboratory culturing of the latex to pressure tests with air, to electrical transmittivity tests with brushes. So many ways to ensure that condoms are safe and efficacious. So prior FDA did not have a large range of condom sizes approved. And so in the red box, you can see there are two red boxes, one by length and one by width. And those were the allowable range of condom sizes to be sold. So, and interestingly, when you looked at the Magnum condoms, they're a couple millimeters bigger than the standard condoms. It's a lot of marketing there. And especially because they couldn't be that much bigger. There wasn't much range that was allowable. And part of this, and so the blue bars that you're seeing, these fitted condoms were actually placed for sale in the EU before FDA cleared them. And so this was the EU sales. And what you can see is there's an awful lot of sales that are condom sizes that are outside allowable manufacturing ranges in the US. And so we had some work to do. So we worked with the International Standards Organization. They ended up doing round robin testing across numerous international labs. Because if you're going to do burst pressure testing and some of the other tests, you can't use the same size mandrel. That former, if you think about the glass former that you saw in the previous slide, if you have a much smaller condom, you can't use the same size former, or conversely much bigger, it'll just blow right off it, right? So we needed to have different bursting pressure tests and different mandrel sizes and some other changes. So this was a past change to the ISO standards to allow the testing to be formal with these condoms. Then we did a prospective user survey to inform an FDA 510K application. The 510K application is kind of a similarity application. So FDA usually wants 200 condom users, and they want a total clinical failure, which is slippage and breakage combined, of less than 5%. That's their kind of cut point. And so the total clinical failure rate in our study was 6 out of 203, or about 3%. And in the end, the fitted condoms were determined to be substantial equivalent and approved by FDA. And this is the eventual range of sizes that are manufactured and that ISO approves for testing. So you can see much larger range of sizes. So then we did a clinical trial. I do want to show you guys the video that we used for this, because you have to have fun in research, and I think it's a way to engage your participants. If you're having fun and you're being creative, it can really help have your participants have fun and be engaged. So I'm going to stop the share. I'm going to start a new share. All right. Let me know if you guys can't hear the volume here.
Welcome to today's sex ed class, where we are going to teach you how to do something groovy. Measuring your penis to determine your fitted condom size by using this condom fitting tool. Remember, this is an important part of leading a healthy and funky lifestyle. We're
Oh, there we
going to
go.
start with this carrot here. Maybe you have a zucchini, but work with what you've got. You know what I'm saying? On the fitting tool, letters are used to determine your length, and numbers are used to determine your girth. Make sure you have a firm erection. Nobody likes a limp, overcooked carrot. Place the base of the measuring tool at the pelvic bone and lay it flat on top of your erect penis, and not just the pubic hair, so push those sprouts back all the way. Your length is the letter at the tip. For this cucumber, it's a length of B. For this zucchini, it's a length of D. Congratulations! Make sure to write it down after measuring. Place the bottom of the tool at the middle of your erect penis and wrap the tool firmly around. That arrow will point right to your sides. This banana has a girth size of 99. Nice! Go to the study website, enter your fitted condom size, and we'll see you at your study visit. Great job today. I'm really proud of you. As for me, I'm gonna go cook up a stew.
So back to my PowerPoint presentation, which is much less engaging. All right, so we like to create user videos that really will engage participants and make them feel invested in the study. And we'll see if that pays off in a moment with our retention data over time. So we created a pretty complex trial design. We really wanted to think through, like, what are the major limits of current clinical trial research in condoms? One of the things we saw was that a lot of studies, they use paper forms, which is suboptimal for recall. And they were paying people per form. So they'd have a visit after a couple weeks, after giving people some condoms to try. And they'd say, okay, if you return all 5 forms, we gave you 1 form per condom. Return the 5 forms, it's $10 per form. And we thought, wow, that's a great way to have people make up data and to bias them towards, incentivize them to maybe not tell the truth that if they didn't have sex 5 times in the period. And in fact, we know that people in the US average 1 to 2 times a week, maybe 3 if they're super sexually active, but 5 is actually a pretty high number to do in a 2-week period. So what we did was we incentivized people to complete a daily diary and to come to the visits, but not for condom use. So they were incentivized to complete it. They got the same incentive if they reported no use as if they reported condom use. And then we also allowed people to finish in as little as 6 weeks. But if they didn't finish a batch of condoms in 2 weeks, they got an additional 2-week period. So there was anywhere from a 6 to 12-week study time period. And so here it does make the chart a little complex, but basically we started with 542 people attending the baseline visit and enrolled. Half were men who have sex with men, half were men who have sex with women, 250 in each arm. And we ended up retaining over 80% in each study arm. So 200 MSM, 209 MSW. So pretty good retention over time. A lot of folks who weren't retained had, lost the relationship or whatever and just said the study's no longer a good fit for me. So here are the results. We were really surprised by these results. So remember, the FDA approval threshold is 5%. We found very, very low clinical failure. And I think, people were completing a daily diary every day. And so we really had pretty real-time data about what was going on with their condoms, and there was no incentive to report use or breakage or slippage or not. So we're pretty confident in the data. And what we found was that there was slightly lower clinical failure for anal sex than for vaginal sex. And this was the opposite of what we expected. The prior literature was all over the map, to be honest. The estimates were all over the place, but usually anal sex had higher clinical failure. Interestingly, there were no substantial difference. We also had 3 different types of condoms that we were crossing people over to use. We had fitted condoms, standard condoms, and thin condoms. And there weren't substantial, none of those differences in those groups were significant. However, the difference between anal and vaginal sex was significant. I mean, notably, all of these failure levels are well below the approval threshold. So really, I mean, the main takeaway for us is that when condoms are used for anal sex, there's remarkably low clinical failure. Now, notably, we did a secondary analysis. We hypothesized that maybe the difference between anal and vaginal sex failure was due to the use of lubricant. So everyone was provided lubricant, MSM and MSW participants. However, the instructions were different. We based the instructions on WHO recommendations. WHO recommendations say for anal sex, always use lubricant. For vaginal sex, use lubricant as desired. And that is how we instructed participants. And so we did an analysis where we looked at, I mean, for anal sex, there's almost universal lubricant use, but for vaginal sex, it was mixed. So when we looked at just persons who reported using lubricant with vaginal sex, there was no longer a significant difference between anal and vaginal sex clinical failure. So we think that this is, you know, obviously exploratory analysis, but biologically plausible that lubricant is the key to having really low clinical failure for anal sex. So we wanted to work. We've been discussing with FDA a FDA label indication for anal sex. So there have been prior to this study, there have been over 360 approvals for vaginal sex. FDA had never had data submitted to them for an anal sex label indication. They didn't even know where to put the cut point. So if I pop us back one slide, that 5% approval, when we negotiated with them about this study, we asked them, what's the threshold? And they said, we don't know. Run your study and we'll see afterwards, which I think is pretty reasonable, actually, because nobody knew what the actual level was. There hadn't been a real clinical trial on this issue. It turned out that the 5% threshold was fine for anal sex as well. And so we submitted the packet in 2020. It was the first ever label sex indication for condoms. It was called a de novo. FDA had some concerns regarding literature review and requested additional information. We held an expert panel. We did a systematic review. And in the end, with our data and this extra bit of work, we had FDA clearance and the first ever label indication and that extended to both standard fitted and thin condoms for anal sex. Okay, so that's condom research. I want to talk a bit about mHealth research. And so I want to talk about some successful case studies. I'm not going to go too far into detail on each of these because I want to kind of explore some characteristics of mHealth studies that seem to work. So PrepMate is a study by Al Liu and Susan Buckbinder and colleagues. This is an SMS support for PrEP retention and adherence. And so this is patterned after the WellTel model weekly text message check-ins. So it's an automated check-in. There's daily pill reminders for 2 weeks, and it's optional for people to continue. And their hypothesized impact was primarily through personalized communication. So people got these automated reminders, but then if they were having any problems or had any questions, as soon as they texted back, they got a real person. So it was a nice kind of virtual and real human interface intervention. And what we can see, this is the EPIC RCT. The study population was young men who have sex with men and transgender women, aged 18 to 29. It was looking at PrepMate versus standard of care. There was pretty good visit retention, but what you can see is that the folks who are not in PrepMate actually dropped off out of care sooner than folks who had the PrepMate. And then also when we look at levels of PrEP adherence is determined by dry blood spot. You can see also that PrEP adherence is higher among PrEP versus standard of care. You can also see this really substantial problem that retaining people in PrEP care is a major issue. I have a couple of publications on that too, but I don't have time today to get into it. But I think it's a really critical issue for the field to sort out. Is keeping people in care longitudinally is really, really hard for PrEP and going to be an important challenge for us to address as we move forward. And so here's the clinical trial article, but also just noting that for evidence-based interventions, they can be added to CDC's compendium of evidence-based interventions. I know Gina has some in there too. So a nice resource for community groups to be able to use and potentially use CDC funding towards these efficacious interventions. So I wanted to talk about an initiative from CDC that's also co-led by one of my collaborators at Emory, Travis Sanchez. And this project is called Together Take Me Home. The goal is to deliver 1 million HIV self-tests, and it's just a really simple website order format. Folks who are eligible are greater than 16 and live in the US. It's a $41 million investment from CDC, so pretty substantial. And it's a very, very multi-sectoral collaboration. So NASTAD is on board. There's this community organization that works a lot with app companies, building healthy online communities. They've been very active in this space. They have another similar project, and so they're a real groundbreaking group. CDC, and then Grindr. You can see on the right, Grindr was using their app to allow free advertisements and getting people informed that they could get a free HIV test. I think that's really critical, bringing in business. Then OraSure was involved, the testing company, and Emory. So really a very broad coalition. And they have actually, I think they have a 5-year study period, but they're moving so quickly, they're going to be done well ahead of time in terms of delivering the 1 million tests. So I think, when you start a big program like this, you worry, well, we'll be able to generate the demand. And in fact, there's been more than enough demand. So, building this public health resource, making it easily available, minimal barriers to get into it has been very successful. So we did, to my knowledge, the only study of covidtest.gov. I know it's a brief departure from HIV, but if you'll allow me, it fits in the theme. So we had a national survey called COVIDview. It was a national sero survey, and we wanted to look at how people were using covidtest.gov. Because it's a probability sample survey, we can then take the numbers, and they're weighted properly to estimate the total number of persons in the US and households in the US involved. And so we estimated that 1 in 3 households had used a covidtest.gov kit. And this is actually pretty early. These kits stayed available for longer. So I think the true number is actually probably going to be quite a bit higher than this. But this was a minimum estimate early. So we had 128 million households. That's the whole US population. And then we estimated that 94% were aware of the program, that 60% ordered it, and that as of the time of assessment, that 41 million households had used one of these tests. Again, I think that number also would go up as people had the test for longer. So really interestingly, the COVID test modalities, here we looked at different modalities. So if you look from left to right, it's lab or clinic tests, drive-through tests, covidtest.gov tests, and other home tests. So one interesting thing is just what an absolute dominant market position that covidtest.gov became, that this really easy to access program was really heavily used. So that's really encouraging. And it's a public health good. And so it was a real benefit to society to have these tests being used. And then if you look in that red box, what you see is that for most home tests, there's an enormous, absolutely low level of use by Black persons in the US. right? So very, very stark racial ethnic disparities for all other home tests. But for covidtest.gov, it basically erased the disparity in tests by race ethnicity. And so what we see is that, I mean, my takeaway is that if you make something publicly available and easily accessible, it's a pretty good start to dealing with major health disparities that we see in our country. You know, we really have a lot to do to lower barriers to seeking care. Okay, so I wanted to talk a bit about this community-based organization in China that I was really inspired by. They call this the Coast Service Community Center, and they have their own app. I'm not sure if any CBO in the US has an app that is anything functional like this, like HIV CBO in the US. I mean, it's amazing the functionality of this. They have live and short videos, they have interventions. That you can see the staff is really made up of community. I believe, I don't know if this is later in the presentation or not, but I believe that they've been so successful in their app development that like the local businesses started asking them to develop apps for them, and they use that as a source of revenue to support their other services. So their app allows for at-home testing. And so this was based on their like app and a WeChat system. They provide online self-test kit applications. So in 2022, they had 18,000 about MSM participating testing and 4,800 kits tested, requested online. They had a low positivity result. And we've seen this in the US too, that when you mail kits and you don't have a good way, even when you try to minimize barriers for return, it's tough to get people to tell you what their results was if they're positive. I mean, that's the hypothesis, right? You don't know for sure, but you find these low levels of HIV positivity, which seem unlikely. So this group created a whole other system for testing. They decided we need another alternative. So what they did, they got 400 volunteers in their city to register on the platform. Then those volunteers shared their locations with the app. And whenever somebody wants an HIV test, they can pop into the app and they'll see the volunteers and their locations. They could be like, oh, I'd like to go testing with this person because this person's nearby. The CBO then pays for them to go get coffee together and do an HIV test at the coffee shop. So with this model, they had 13,000 making face-to-face appointments with this. And that was an increase. And they increased their positive. So for offline testing, for this in-person, the positivity rate was 2%. So they're, you know, really such a creative solution to a really tough problem and so community friendly. I just thought, wow, we have a lot to learn from other folks in the world, and we should be humble in the way we approach, you know, international settings, and the innovation of other groups is so inspiring. So I just love this group. I think they're doing such good work. And the amazing thing is that every CBO that I interacted with in China had an app like this. Like they all had apps that were highly functional and very user-friendly and quite wonderful. Really interesting, very advanced technologically. So I want to talk a bit about the Blue Plus study. This is how I started working in China. So Blue is a geosocial networking or dating app, has over 12 million monthly users in China. Keep in mind, there are only about 4.5 million MSM in the United States. So a really substantial user group, very, very large population. And, you know, Blue is like, the best way I can think to describe it is like if you took Grindr and Jacked and Scruff and every other dating app for MSM and like wrapped into one platform, that's Blue in China. So we had this concept to improve the health platform functionality within the Blue app based on Emory's evidence-based health minder app. And that's Blue Plus. So our idea was to build directly into a dating app and pilot test a prevention platform. So again, lowering barriers, right? There's a theme here, lowering barriers to access. This is where people are going to, you know, look for partners. Why not offer them prevention services right there in the app? And so we did some cognitive interviews and focus groups to develop the intervention. We ended up having a prep program that included online ordering, in-person lab tests, and then online clinician visit and a mailed prescription. We had at-home HIV test ordering, condom and lubricant ordering, and different options for the condoms and lubricant, and then HIV prevention messages periodically to support use of these prevention goods. The services were all offered without cost, which emulates health department provision of the services. And then the study was done in Beijing and Chengdu among people who were not taking PrEP at baseline, but were PrEP eligible. So we actually, I think we did have people who were taking PrEP at baseline. So I think we ended up relaxing that criteria, sorry. So we enrolled, we started with 625 enrollment. We were able to get in touch with 440 of those persons. And by month 6, we had kept 400. So really, really high retention levels for this study. And everyone in the pilot got the full Blue Plus package. What you can see is that through the platform, so if you look on the right, that's kind of the cumulative use of the platform at the individual level. So 38% of persons offered the platform initiated PrEP through it. 63% of participants ordered a blood HIV test, 10% ordered an oral HIV test, and 12% urine HIV test. And then 80% ordered condoms and 80% ordered lubricant, because once they ordered condoms, we said, and here's your lubricant. Okay. And so here are the kind of results compared. So we did a repeated cross-sectional survey. The specific mechanism we were funded in under NIH did not allow for a clinical trial. So we could not do a clinical trial. We could not have a control group. And so we had an intervention group, and then we did cross-sectional surveys in the study cities at the same time as we did the measurement for the Blue pilot cohort. I mean, the nice thing about, one of the nice things about doing research in China, I think we enrolled our study of 400 within like a week or week and a half. And so then the 6-month survey hits at the same time for everyone. And so we're able to then do the cross-sectional survey at the same time for everyone. So it's actually almost identical in time, the cross-sectional surveys and the assessments of the pilot. And what you see is that in blue, you have the intervention pilot, and orange, you have that repeated cross-sectional survey control. And you see much higher levels of PrEP use at 6 months, higher levels of HIV testing, and no substantial difference in condomless anal sex. So despite offering them nice condoms, that didn't change. But we were happy to see the changes in the other areas. So some conclusions about some of the successful mHealth programs we've talked about so far. One is that broad access seems really critical. So 5 of the 6 programs, I'm now including PrEP Locator in this grouping, had broad access, easily accessible, easily comprehensible. None of these were overly complex. None of them had, huge lists of FAQs or really complex sets of information presented. Quite simple. Few eligibility criteria. So not a lot of barriers to prevent people from using the service. And so I think, maybe accessible programs are one important part of addressing health inequities. The simple may be more important than we give it value. Another thing notable is that it's not always an app. We love apps in health research, but the majority of these were text-based or websites. And last is that multi-sector partnerships seem to be a really critical piece to resolving mHealth scale challenges. It's really hard to bring mHealth apps to scale. I did a review in 2020, I think, looking at NIH-funded app research. And at that point, there were 0 apps that were publicly downloadable for HIV prevention that had been funded by NIH out of 40 grants. Now it's slightly increased. I think there's 1. And so what we see is that, if we want to bring, health solutions to scale, we really need multi-sectoral collaborations. You need the government involved. You need CBOs. You need businesses, or you benefit from having businesses involved. That really helps. I think evidence-based intervention program of CDC is really promising. And last, building on existing business models can bring rapid scale. So in some cases, if there are already businesses like WellTel there's already a business, that like Blued, that can facilitate scale as well. I wanted to briefly, I know we don't have too much time, so I just have a tiny little plug that this is a paper that I did with colleagues looking at the impact of PrEP policies. And this was just an associational study. We're working on the next phase of this research. Recently received NIH funding for a project called Premise to look at policies in quasi-experiments. And so looking at PrEP DAP, PrEP drug assistance programs and others and other programs and looking at their policy level impact on PrEP use in the US. But here through quasi-experiments, but you really need pretty nuanced longitudinal data for that. In this case, we had cross-sectional data. We were looking at associations of PrEP policies with PrEP prevalence and PrEP to need ratios. And what we found was that states that had PrEP drug assistance program or Medicaid expansion had slightly higher, but not significantly higher, significantly higher PrEP prevalence and slightly higher, but not significantly higher PrEP to need ratios. States that had PrEP drug assistance programs and Medicaid expansion had much higher levels. So as a ratio of 2. So it's like almost a twofold increase in PrEP use in states that have these drug assistance programs and Medicaid expansion relative to reference states. And also the PrEP to need ratios improved in those states relative to the reference. So a pretty strong signal, and we're looking forward to doing the quasi experiments to really tease this out, but a very encouraging signal that maybe these policies, and it's not shocking, right? There are other studies that show at the more like individual level the effect of these PrEP navigation programs and other kind of assistance. And so you could see that maybe once we start at the policy level, scaling it up at the state level can actually have a similar visible impact. So I want to kind of close with this kind of discussion of US guidelines to indicate people for PrEP. So here's the very simple guidance that clinicians have to use now. It's not very simple, is it? It's pretty complex. It's hard to go through all this. So you see that people are either told to prescribe, clinicians are either to prescribe PrEP or to discuss PrEP and prescribe if requested, which I think many people would just interpret as don't prescribe PrEP. But that's not what it says. Depending on different risk factors, and this is for all sexual transmission routes. And so, we see that, overall behavioral risk factors perform poorly in predicting HIV in the US. So a 2017 cohort study found that these simple demographic characteristics predicted HIV better than the entire battery of existing behavioral screening tools. So simple demographics outperform like very long, complex behavioral screening tools for HIV incidence. And I mean, this is similar to Greg Millet's meta-analysis in 2007 that showed that Black MSM, the men who have sex with men, have equal or lower behavioral risk than white men who have sex with men, but experience still very, very high levels of HIV incidence. Another study that kind of supports this is on the right, and this is a study done by John Schneider and colleagues, and what we see is that the PrEP indication relative to levels of HIV is lower if you follow the indication guidelines for Black and Hispanics than whites. So that if you follow the guidelines, they will definitionally create inequities. And we found almost the identical thing in another study. So I think, seen across studies, the guidelines are kind of inherently inequitable because it's only about behavior, and we know that behavior doesn't actually equate to risk. So how do other modalities deal with this? So the U.S. Prevention Services Task Force has guidelines for statins prescribing, and this uses a 10-year estimated cardiovascular risk of 10% or greater. Notably, this is basically a 1% incidence threshold. And you may note that like in these risk thresholds, people are not asked to self-report factors with known social desirability bias. They're not asked to talk about their diet. They're not asked to talk about their exercise regimen. It's just a simple calculator. to see if statins are needed. Here, for colorectal screening, we see that groups with family history, which is kind of a proxy for higher incidence, start screening sooner. And finally, WHO uses a 3% incidence threshold for PrEP eligibility. So, basically some other areas, they use the epidemiology much more directly, the actual levels of risk in the group, rather than trying to solely locate eligibility based on behaviors. And given that we know behaviors don't predict incidence super effectively, that seems like a reasonable approach to me. Now, is 3% the right level? I think some would argue no. Here's a little figure from Chris Byer and colleagues, looking at the impact of 3% versus other thresholds on number needed to treat. But so 3% may not be the exact right level, but it is feasible. So what would happen if we use something like that in U.S. indication guidance? It could be in addition to current behavioral guidance, so sitting above it as a kind of screening threshold that people could be indicated for PrEP based on. Obviously, the exact incidence cut point would need to be determined, right? It could be a 1%, could be 0.5%, could be 1.5%, to be determined. Information could be provided to clinicians in several ways, through simple tables or through online calculators, similar to cardiovascular risk. And the nice thing about doing this is that the electronic medical records could probably be prompted to notify clinicians of PrEP eligibility if we use this approach. The behavioral approach is just behavioral only approach is just too thorough for EMRs to really document. So some advantages of this, I think it could easily increase health equity. It allows honest counseling for individuals because we know risk is not best predicted by their behavior. It's really based more on community viral load. This allows PrEP initiation without persons self-classifying as high risk. So I think that might avoid stigma, in that people don't have to self-classify as high risk. They may not be high risk, but they're still at risk for HIV due to the population they're in, rather than due to their individual behavior. And last, I think there's a clinical benefit to ease screening burden and to facilitate retention and PrEP care. So there's some disadvantages. Obviously, incidence data may not be readily available in consistent formats for all groups. There's some analyses that would probably need to be done and some modeling. Obviously, the process needs to be done to determine cut points and analyses to support that. And then periodic updating of incidence data would be required. It's not a panacea, right? There are numerous barriers for people to receive PrEP. And numerous improved healthcare and policy solutions are needed. But, again, tackling the easy things and reducing barriers to care, I think is a critical part of what we do. And I'm currently working on kind of a thought piece to pull all this together and make a case, hopefully in the long run, to CDC and U.S. Prevention Services Task Force about really thinking through like what's the best way that we should be making people eligible for PrEP. Okay, so some conclusions about seeking paradigm changes. There are really numerous routes for public health impact in HIV prevention and treatment right now. There are policy interventions and structural. There's regulation. We have new products that are coming out all the time. FDA approvals for those products are needed and often can be nuanced with delivery modalities. So even once certain injectables are approved, there may be delivery mechanisms for self-delivery or for mobile delivery that need to be assessed. Novel interventions can be done to support prevention, and mHealth programs that are easily accessible can be built. I think central to all of these is facilitating access to prevention choices for people, helping people make their best health choices, and minimizing barriers to doing that is such a critical part of what we should be doing in public health. And then last, I really believe that seeking scholarship that one believes has a probable public health impact that also leads to high quality scholarship. I think these two things are really mutually supportive. And so as we determine with our very rare research resources and time and effort about what projects we should focus on, I think following the line towards public health impact and what you think leads to public health impact also will lead to great scholarship. So last, I've to thank the funders, predominantly NIH, also some foundations. thanks to many collaborators, including dearly departed Dawn Smith, and thanks to so many staff and so many collaborators across many, many institutions. Please feel free to contact me at any time. That's my email. And I just want to close with the Emory Prevention Implementation Sciences Corps offers consultation and services to advance HIV research. This is offered regardless of affiliation to Emory, and we offer access to HIPAA compliant survey platforms, access to study management and retention tools, and then we also offer training for various things. So happy always to facilitate access to junior investigators, especially to resources to help advance their careers. So with that, I'm going to close, and thank you all very much for your time today.